Riedel's thyroiditis. It is also known as Riedel's stroma or chronic fibrous thyroiditis, and it is an extremely rare and poorly understood inflammatory process causing diffuse destruction and fibrosis of the thyroid. The primary theories for the etiology of this disease are that it is either an autoimmune process or a specific fibrotic disorder related to multifocal fibrous sclerosis. The most relevant finding in Riedel thyroiditis is the presence of an extremely firm and constricting gland that can be very uncomfortable for patients. The fibrotic process often extends into surrounding structures, including the aerodigestive tract and recurrent laryngeal nerve, which may cause clinically significant airway obstruction, dysphagia, and dysphonia. Patients with Riedel's thyroiditis have a biochemical markers of hypothyroidism. Imaging is necessary to rule out other causes of the dramatic local symptoms. Ultrasound characteristics often demonstrate a diffusely hypoechoic gland with ill-defined borders. FNA cytology reveals dense fibrotic changes but cannot be reliably distinguished from fibrotic changes, often associated with anaplastic thyroid cancer. Medical treatment to treat the inflammatory component of Riedel thyroiditis traditionally consists of corticosteroids and tamoxifen. Other agents such as mycophenolate and rituximab also have been used. Thyroid hormone supplementations or replacement is used to treat the associated hypothyroidism. Surgical resection is often indicated to rule out malignancies such as anaplastic thyroid cancer or primary thyroid lymphoma, or to treat aerodigestive tract obstruction. Surgery is usually extremely challenging due to the firmness of the gland and obliteration or normal planes and landmarks. Partial resection of only the affected components is recommended, with simple wedge resection of the isthmus being the most common surgical therapy for relief of tracheal compression. There is no evidence to suggest that Riedel thyroiditis is associated with an increased risk of thyroid malignancy. Now the next one is acute suppurative thyroiditis. It is rare and defined as an acute pyogenic infection of the thyroid gland. The most common underlying cause is the infection of a congenital pyriform sinus fistula, which tracks and communicates with the thyroid. The clinical presentation of acute thyroiditis is that of the bacterial infection, fever, severe unilateral pain, and swelling of the thyroid gland, typically left-sided, and cervical lymphadenopathy. The most common organisms include the Staphylococcus and Streptococcus species, but the other aerobic or anaerobic species also may be involved. The thyroiditis can also lead to thyroid abscess formation. Rarely, it can lead to even more serious sequelae, including retropharyngeal abscess, tracheal obstruction, mediastinitis, and jugular venous thrombosis. Thyroid function tests are rarely useful in the diagnostic of acute suppurative thyroiditis. Rather, other biochemical findings of acute systemic illness and sepsis are more useful, such as the complete blood count marked by leukocytosis with a left shift. Ultrasound with FNA biopsy can also be used for bacterial culture and speciation of any abscess fluid. Treatment consists of appropriate spectrum antibiotics as well as percussionist drainage of any identifiable abscess. Acute thyroiditis does not generally lead to long-term hypothyroidism requiring thyroid hormone supplementation therapy. Moving on to iatrogenic hypothyroidism. Aside from post-thyroidectomy hypothyroidism, due to the absence of sufficient thyroid parenchyma, pharmacotherapy is the primary cause of iatrogenic hypothyroidism. The number and variety of medications and therapies are associated with hypothyroidism are extensive, which is shown in this box. You can take a screenshot or pause the video to look into all the drugs that can lead to the iatrogenic hypothyroidism. The most common medications associated with hypothyroidism include radioactive iodine, antithyroid thienamides such as methimazole and propylthiouracil, midarin, lithium, immune modulators, and kinase inhibitors. The etiology of drug-induced hypothyroidism depends on the specific agent. In the case of RAI therapy, the often expected hypothyroidism is due to direct destruction of the thyroid follicular cells by the delivered radioactive agent. Thienamides such as methimazole and propylthiouracil directly inhibit T4 and T3 synthesis as well as block peripheral conversion of T4 to T3 in the case of propylthiouracil. The antiarrhythmic agent amidarin can lead to both hypothyroidism and hyperthyroidism due to a number of mechanisms, including inability to escape from the Wolff-Chaikoff effect from the drug's high iodine content, inhibition of deiodinase activity, inhibition of thyroid hormone entry into periphery, and direct cytotoxic thyroiditis. Lithium may act by directly inhibiting the cyclic AMP-dependent pathway leading to a thyroid hormone formation in the thyroid follicle. Tyrosine kinase inhibitors such as sunitinib and vanitinib cause hypothyroidism in different ways, including direct destructive autoimmune thyroiditis, reduction in vascular endothelial growth factor VEGF-related thyroid vasculature, and reduction of thyroid iodine uptake. Treatment of drug-related hypothyroidism usually consists of removal of the offending agent if possible, as well as thyroid hormone supplementation or replacement as necessary.